Hello, good evening, and welcome to this your weekly medical show, Ask Dr. Saw. I'm your host, Akash Prasad, and with me in the studio is the man himself, Dr. Saw, which we will be asking questions to. Last week we were closing up on diabetes. There was one more thing that I would like to ask him about, which is that, as I promised last week, which is OZEMPIC. We're going to be talking about that a little bit before we go into tonight's topic, which is hypertension. And from next week, just to let you know, from next week, we will be going live in studio for 1 hour. So from next week, the 8th of October, Tuesday, the 8th of October, you will be able to call in and you're going to be talking to us about various problems that are affecting you or any one of your loved ones or so. But, thanks for the overwhelming response that this show has been getting. We encourage you to share it with your family and friends and let them know what's happening here. That show, when we start live, we're going to be doing 15 minutes of dealing with a specific topic for the evening. And the other 45 minutes will belong to you and Dr. Saw. He will be taking your questions. He will be answering health questions about health issues and all of that. And hopefully we give you the best answer. Doc is very capable. But Dr. Saw, we're here again, and it's such a wonderful experience to be doing this show because we're bringing something that I think really was needed to the public. Many of our viewers are from the diaspora, and I know that they're enjoying this show also. So let's go to but how was your how has it been so far?
Yeah, I'm doing all right. Adjusting well, and I think
Good guy needs food, right?
All the time.
Yeah, man,
that's something you can never get too much of.
Yeah. Before we go into hypertension, I just want to touch quickly on this. You mentioned last week OZEMPIC.
Yes.
And I want to touch on it because across the internet recently it was splashed all over social media about this wonder drug called OZEMPIC. And I said, wow, well, what is it? I said, but he said, oh, it's this wonder weight loss drug. It's this drug for weight loss. But here you are telling me that OZEMPIC, it's a treatment for diabetes.
Sure.
So tell me a bit about OZEMPIC.
Yeah, no, indeed. So Ozempic, as we know, when I spoke before about the types of drugs, the classes of drug that we have for diabetes, Ozempic came into that class. It's a class called GLP-1 agonist. So Ozempic is a brand name. The drug is called semaglutide.
Okay.
So the brand name is Ozempic. There is also another brand called Wegovy that is licensed for weight loss. But the drug itself, the generic or the chemical name of the drug is semaglutide, and I've been using it for years for diabetes patients.
So it's been around for a while?
It's been around for a while. But recently, and well, not recently, but, a while now, a few years now, we find that lots of patients who are taking it for the diabetes, they have weight loss. And it is established in all the trials that they've done, patients lose a lot of weight from the drug as well. So now it is licensed for weight management. But just to clear this up, the generic drug is semaglutide, and there are two brands of the drug. Ozempic is a brand that was licensed really for diabetes, and Wegovy was a brand that was licensed for obesity.
Okay.
But it's the same chemical in the drug. It's just the marketing on the drug company, how they market it was different brand. But now people are using interchangeably. So they would use Ozempic for weight loss as well as Wegovy, whichever one is available. Now, because the demand is so much, because lots of people are using it only for weight, then you end up, the shorter supply. But never mind. Let us talk quickly on the drug itself and when do you use it, when do you not use it, what are some of the precautions and side effects.
And exactly, and complications if using it for weight loss, if there are any complications, because if I'm going to be using it for weight loss and it was really meant for something else, what are the implications of that?
No, let me clarify. It is licensed for obesity as well.
Okay.
But what I'm saying, initially, it was licensed for diabetes, then the license for weight management, but they give two brands of the drug. The brand for weight management was different from the
Right.
brand
Yes,
for
you did
that.
say-
But
yeah.
then because it's interchange, we know it's the same chemical, of license use, we use it all the time and get the same response.
Okay.
Now, let us go through the drug. How does the drug is indicated for diabetes, obesity. Now, when do we give it? Lots of people come and ask, for Ozempic. The guidelines tell us that if your BMI, so you heard of BMI, so that
right.
is your body mass
Mass index.
index. If it is over 30, we can go straight for the drug. That is obesity. So if your BMI is over 30 and you don't have any other complications, you can say, Doc, can I have the drug? I'll say, fair enough. It's licensed, and I'll give it to you. If your BMI is 27 and above, but you have one risk factor, diabetes, heart disease, or any of those risk factors, cardiovascular risk factors, I would give you the drug as well. So it would use both for diabetes and for obesity with risk factors. Now, how does the drug work? There are multiple mechanisms of action. It works by slowing the GI tract, so the emptying of the stomach, it slows that down. It decreases your appetite. It stimulates insulin, and it decreases a hormone called glucagon. So glucagon causes you to raise your sugar. So when your sugar is low, glucagon takes it up. When you have high sugar, you secrete insulin to drop the sugar. So it has multiple action. So it works by decreasing absorption, so low gastric, increase insulin, decrease glucagon, and it decreases your appetite. So multiple actions. So we understand that. Now, bearing in mind, I said it slows the stomach.
Yes.
And absorption. So what you can have complications from that. So we are wary of lots of patients. So the common side effects of the drug is GI upset. So patients will come and say, Doc, I feel nauseous, I lose an appetite, which that's how it works. I feel bloating, I have some erratic bowel habit, diarrhea, vomiting, nausea. That's bloating. Those are GI upset. And that's a common side effects of the drug. We are also aware that some patients, diabetic patients, can also have something called neuropathy, where the stomach don't empty good enough. And that's a contraindication for the drug. It's called gastroparesis. So if your stomach is not working well, whereby you already diagnosed with a stomach disorder, that your stomach is not emptying properly, you should not take the drug. Okay. Secondly, there are patients with severe constipation problem, and they also have it can cause bowel obstruction. So if you've had previous bowel obstruction, you're prone to bowel obstruction, I would not prescribe the drug because it slows the GI tract. Okay. So you have to know when to use it, when not to use it. Mm-hmm. Now, there are some other side effects. Pancreatitis. So I don't know if you know what is pancreatitis. Pancreas produces insulin, but it also produces digestive enzyme. Right. So alcoholics and people who have got other conditions can have inflamed pancreas. I would be wary of giving the drug in pancreatitis patient. And another side effect, gallbladder disease. So the drug has got side effects where it can cause inflamed gallbladder, gallstones, inflamed gallbladder, infection of the gallbladder. I will, be cautious of that. Not it is totally contraindicated, but you have to be cautious of that and advise patients if they have inflamed gallbladder symptoms to stop the drug. Now, important. This is a very important one to note, and patients are usually, they will come and clarify, Doc, does it actually cause cancer? Now, thyroid cancer, they've done studies in rodents, in rats, and they found that it can cause thyroid cancer in rats. Okay. We haven't seen that translated in humans as yet. So we don't have studies to tell us that, yes, it does. But the caution is, in patients who are diagnosed with thyroid cancer, that is, thyroid gland is in the neck, I would not prescribe the drug, and it should not be prescribed. And also, there are some genetic condition you're born with, Men's syndrome they call it, that you can have a predisposition for thyroid cancer. In those genetic conditions, I wouldn't give the drug. So, knowing that it's a wonder drug, of course, it's a weight loss drug, and it's said these days that maybe this is a drug to replace bariatric surgery, that is surgery of cutting the stomach. Uh-huh. If it is a drug to replace it, it has got a place. I am happy for that. However, you have to be cautious of the side effects and also aware of them, that if you were to have them, you don't take the drug. Now, how do we give the drug? Because just quickly, it's a weekly injection. We start at a low dose, and we would up titrate the dose. So every 4 weeks, I will then up the dose incrementally, and both for diabetes and for weight management. So that's a summary of Ozempic. It's a good drug. I've used it a lot in my patients, even before. There are other drugs came out in the family of GLP-1 agonists, liraglutide. So this is semaglutide. There's another one called liraglutide. The brand name is Saxenda. I've used that for many years as well. I've seen good results in that. And there is one called Mounjaro. Have you heard of that?
No.
Tirzepatide is a chemical name that also has got even better evidence as Ozempic from the trials that have been done.
Wow.
And it's being used routinely in the US and in the UK.
Well, thanks. Well, thanks for touching a little bit on Ozempic, because a lot of people we're hearing about this drug, and there are so many things being said about it, but thank you for clarifying that, because there is so much been going on social media about this drug and what it does and how expensive it is, and only the elites can afford it and so on, because it is being peddled out there as this wonder drug for weight loss. But you did clarify what that is. But let's talk about our topic for tonight, which is hypertension. Look, I hear a lot of people always like, what's wrong with you, man? My pressure high, my pressure low. I gotta go test my pressure. The first thing you walk into a clinic, the first thing they do, they actually test your blood pressure. Doc, what is hypertension? What is high blood pressure? And why is it important to identify that this is an issue and have it sorted?
Lovely. So hypertension, as you rightly say, is high blood pressure. And as you know, our heart pumps blood, and the blood moves around the body. Mm-hmm. So for it to move around the body, it has to maintain a pressure for it to circulate. And that is called blood pressure. Mm-hmm. So that's your blood pressure. Now, hypertension is defined when the blood pressure reaches a threshold. Beyond that threshold, we'll say that is hypertension. So the threshold, so blood pressure is made up of two numbers. One is called the systolic, which is the top or the higher number, and the other one is called the diastolic. Now the systolic should be between 90 and 140. If it goes beyond 140, that is high blood pressure. And the diastolic should be between 60 and 90. And if it goes beyond 90, that is hypertension or high blood pressure. Now, bear in mind, there are two numbers. So lots of people think, well, my top number is high and the bottom is normal, or my bottom is high and the top is normal. It doesn't matter which one. So it could either be either one high or them both high. If either one high or them both high, you're hypertensive. Once it's beyond 140 and upon 90. So beyond 140 on the top, beyond 90 on top is hypertension. Now, why this is important? That's a good question. Just to give you some data, the WHO data, that's World Health Organization data, 1.28 billion adults suffers with hypertension. But here's the thing.
Wow, 1.28 billion adults between the age of 30 and 79.
Correct.
That is huge.
And this is remarkable and scary. 46% of those patients don't know they have hypertension.
What?
46%, close to half of the people don't even know they're walking around. Because the thing about hypertension, you don't get symptoms usually. It's only when it's severely high or you get complications. Mm-hmm. And walking around, half of the patients are walking around without knowing. And that is why it is important to get checks, do your health checks. Now, 42% of patients are diagnosed and treated. And of those that are treated, only 1 in 5 or 21% under control. Now that is even scary.
Let me get this.
Yeah.
You mean out of that 46%?
Yeah, who are diagnosed and treated.
Right.
Only 1 in 5 are under control.
Only 1 in 5 under control.
21% of patients. So if you're diagnosed with hypertension, there are tablets you'll take to control it, or if you're doing lifestyle. But lots of people will take one tablet and they say, right, I'm okay. But the blood pressure is not controlled. You may need a second and a third. So when we come on to treatment, I'll tell you how it is managed. Mm-hmm. But the fact of the matter is that we should be aware that even if we have blood pressure and we are taking a tablet, we want to make sure the tablet is doing the job. And that is important. When you look at the data, it's really scary.
1.2, but that's a huge number.
Absolutely, no, indeed. And let us look at why that hypertension important?
Right.
Why hypertension important? 58. So we know if your blood vessel flows everywhere, the blood flows everywhere, and if you have high blood pressure, it damages the blood vessel, and it can happen before it can. If the pressure is too high, of course, ultimately it can burst the blood vessel. So patients can have aneurysm and all these blood vessel issues. However, what happened more before that, you have what we call microvascular damage. The cells of the blood vessels start to go bad, and that increased risk of it stiffens, it increased risk of clot formation and blockages. So that happened at a microscopic level long before you even know it. So when we talk about blood vessel, we talk about stroke. It is attributed, high blood pressure is attributed to 58% of hemorrhagic stroke, that is bleeding in the brain. Mm-hmm. So there are two types of stroke. We call it hemorrhagic and one is ischemic. Ischemic is when there is a blockage and there is no blood flowing, and hemorrhage is when the blood vessel bursts and it bleeds.
Okay.
And then the blood supply shuts off because it bursts and it bleeds. Ischemic is when it's blocked and no flow. Now, 50% of ischemic stroke accounted for by high blood pressure. 55% of ischemic heart disease, IHD, is ischemic heart disease. That's heart attack, angina, heart attack. Then also you have other cardiovascular complications. You can have heart failure. So think about it. The heart is pumping, and when the heart is pumping, it's pumping under pressure.
Right.
So it's like you lifting weights. What happens when you put more weights on? You build muscle. Mm-hmm. So the heart has got a muscle. Let's say the heart size muscle is like this, and the heart is pumping against high resistance. The muscle expands. So it grows bigger. So we call a hypertrophy of the heart. You can see that. If you scan the heart, you'll see that the muscle is enlarged. Now the heart itself has got blood supply going to the muscle. Mm-hmm. If you have a blockage of these blood supplies, then you have heart attack. Now, if the muscle grows and the blood flow is not growing, what happens? You get heart attack.
Yeah.
Logically, because the muscle is bigger than the flow. Mm-hmm. So that is one of the problems. After a while, it can't grow more. It stretches. You get heart failure. So if the pump meant to be strong, sturdy muscle squeezing, and it is thickened, the volume gets less. So you get, thickened muscles, and then it stretches and you get failure. It can't pump properly. And that's why blood pressure control is so important. So besides stroke, heart attack, it can cause damage to the blood vessel to the leg. You have something called peripheral vascular disease, where you get poor blood flow to the leg. Patients walk like how you have angina and chest pain, you get pains in your leg. And also erectile dysfunction. I said to you earlier that blood flow, erection has to do with blood flow.
That's right.
And
yes.
If you have high blood pressure, you can have that as well. So that's the important thing. It can also damage your eyes and your kidneys. And just to put things in context, for every 2 millimeter rise in blood pressure, it is accounted for 7% of death due to heart attack and 10% of death due to stroke for every 2 millimeter.
Wow.
So if you're talking about my blood pressure is 150 and now it's 152, that's the relevance, how important it is. So I feel that it is a topic that, we need to have that very well controlled, because when you look at the leading causes of death, non-communicable diseases, hypertension, diabetes, high cholesterol, all these things, heart attack, it's all, you don't usually, until you get a complication or something severe, you don't know about it. And all these things are preventable.
Indeed. Well, while you were talking and showing the action of the heart beating, Doc, you would not believe this, but I actually zoned into my own heart, sort of, and I can actually feel this heart beating. I'm thinking to myself, I got to take care of this. I have to take care of this. But how do you get hypertension? How do you get...
Right. So there are different causes. So hypertension generally, we say like diabetes, hypertension is multifactorial. So there are two types of high blood pressure in general terms. Just for simplicity, you have what we call essential hypertension, which affects 95% of the people. Mm-hmm. So that is the type of hypertension most people get as you get older. And they have what we call secondary hypertension. Secondary hypertension means it's from another cause.
Okay.
So majority of people, 95%, we would say they have primary hypertension or essential hypertension, and that's the one. that is multifactorial. That is caused by genetic predisposition and environmental lifestyle. So that we can control some of the lifestyle modification, but the genetics we can't control. And then the secondary hypertension, these are patients with kidney disease, endocrine, hormonal problems, pregnant patients get high blood pressure as well. So we call that gestational hypertension or pregnancy-induced hypertension. And that's called secondary hypertension. So really, that high blood pressure is due to multifactorial cause.
But I mean, you're talking about causes here, and I hear a lot of people say, we keep, and this is a local Guyanese thing, and I'm using this because these are some of the questions out there that the public will want to ask. Salt. You hear very often that if you use a little bit salt, this is going to happen. If you eat plenty salt, that's going to happen. What's the...
That's very, very important. So when we talk about management, and I will tell you, we have lifestyle modification and medication, like everything else. When we talk about any condition, I try to go lifestyle first, and then we look at medical management. Now, salt, if we look at high blood pressure, and when we look at the causes, and yes, we say it's multifactorial, but there are certain things that happen in the body. What is blood pressure? Blood pressure is heart rate, stroke volume, multiplied by the number of times the heart beating and the volume that is output. So in physics, if you look at the physical terms, this is a pressure I squeeze here. If I squeeze fast, you get more flow.
Right, that's right.
And so it's called stroke volume or cardiac output, so the amount that comes out and how fast I'm squeezing it.
Okay.
So logically, that's your blood pressure. So there are different components in the body. Now, if I increase the volume of water in this bottle, the pressure will go higher because I'm squeezing more.
Yes.
Logically. So what happened with salt? Salt attracts water. In chemistry in school, you will know when you get a salt, we do something called osmosis, where you have a barrier and then you have salt on one side, it attracts the water into the salt.
Right.
So if you're hypertensive and you use a lot of salt, you can have retention of water with the salt. What happened? Blood volume increases and you have higher pressure. That's just a simplistic explanation, just for us to understand how salt works.
Yes.
Now, there are also some people who are more salt sensitive, and they tend to have high blood pressure because they're more sensitive to salt. So yes, salt is very important.
Okay, good.
So in terms of looking at that, and when we look at medication, I'll tell you how medication works in different forms.
Good.
But
and so how do you know that you have the
high blood pressure?
High blood pressure. What are some of the symptoms? What should we be looking out for? Because as you rightly said, that only 46% of the people from the 1.28 billion people actually know that they have it. So maybe a lot of people are going about it and it's like they're not seeing any symptoms.
Correct.
Maybe.
Well, that's a bad thing. I mean, you're unaware. Majority of patients with high blood pressure, they don't even know they get blood pressure. But you would have heard that patients come and say, "My neck is hurting,"
right?
And they check the blood pressure is high. Actually, the evidence doesn't stack up with that to say every time you get neck pain is due to high blood pressure, or the blood pressure is cause of the neck pain. It can happen. You can get headaches from blood pressure. But usually these are cases of extreme blood pressure, severe blood pressure. So when your blood pressure is severe, so majority of patients, so let's clarify this, majority of patients, they wouldn't have any signs or symptoms. And I know I have, aunts and family who would say to me, all right, I only use my blood pressure tablet when I feel my neck is hurting. Well, you shouldn't. If you have high blood pressure, you should take your tablet every day.
Okay.
But coming back to the signs and symptoms, usually none. But if you have severe blood pressure, you can have symptoms. It can vary from anything. You can have headache, dizziness, buzzing in the air, blurred vision. It can also cause complications, and you can have stroke-type symptoms. So if you have all those symptoms, it means your blood pressure is severe. But for the majority of patients, mild blood pressure, you don't have symptoms. My take on this neck pain business and high blood pressure, two things. Tension. If you're under tension, you get headache, you get neck pain.
Stress.
So one of the ways of understanding when we do headache as a topic, there's something called tension headache.
Okay.
So you go home at the end of the day, your neck is hurting, there's a band around your head, you feel all the muscle tense. You're under tension. If I check your blood pressure, it may be high.
Right.
So it's not a blood pressure causing the neck pain,
Yeah, I know.
but it's the tension causing the neck pain. So let us know, the message here is not that you can't get neck pain. Of course you can get neck pain from high blood pressure, you get headaches, you get dizziness, but the point what I'm making, do not wait for your neck to hurt you to say that this is my blood, then I need to treat my blood pressure. I will treat it, and there are other components, other causes of that neck pain. Right?
Oh.
So majority of times you don't know. So complications, you will get complications of it, but that's in terms of blood pressure. And so that I would then encourage patients to have regular checks.
As I said just now, when you walk into a clinic, one of the first things that they do is that they tell you to sit down. They say relax a little bit. I'm going to test your pressure. Or some people just go to the pharmacies right away and say they're going to test their pressure. It seems very routine, but very important also. There are also some, in this with modern tech, there are some watches that you wear, smart watches that you wear, and it can actually detect your blood
Pressure.
blood pressure. But how is it being measured, and what is the accuracy of let's take the smart watches and so on, or going to a pharmacy or going to an actual clinic?
Good question. So it is important. So blood pressure is, as we know, is a pressure in the vessel, and is measured in millimeter of mercury, mmHg, right? Now, so that's the gauge that they use to measure the pressure. Now there are different devices. So the commonly used device would be the one that you put in the arm. Now there's some specification that I would like patients to know and to understand. So if I have a big arm and I use a small cuff on my arm, so this is a gold standard. So meaning that this is the one that is validated and is well, I would encourage patients to always use the one in the arm. Now the cuff size in the cuff, so you have that thing that you wrap around your arm. It should be on the elbow joint, just above the elbow joint, 1 or 2 finger breadth away from the elbow joint itself. It should fit, you wrap it around snugly, so it shouldn't be too tight. You should get your 2 fingers in there like that. And you should be relaxed. So when you talk about, if I walk straight into the pharmacy and test my blood pressure, I'll just come from a day's work and straight to test my blood pressure. That's not your ideal. You want to be relaxed, you want to be calm, you don't want to be anxious. So you relax for a while, you sit upright, support your back if you can, your arm down resting on the table. It should be at heart level.
Okay.
And then you apply the cuff. Now, there are machines selling. I encourage patients. The machines are relatively cheap. You buy those machines, and everybody with blood pressure should have a machine just to monitor it, to know how the blood pressure is doing. I wouldn't say that you have to monitor it daily, but it's encouraged because when we do medication adjustment, we want to know what's your home reading like. So you apply this snugly and you get it, and you press, the machine tells you how to do that. There is that tubing that comes out of the cuff.
Right.
It should be more in between the center and in the inner part. So in the middle here.
Right.
So this is where the blood vessel runs, and the tubing that comes out of the cuff should be around that level.
Okay.
Right. So that's just for, in a simple way how to measure it, and that's easy. Now, looking at the arm, the wrist, there's a wrist one as well. The wrist one is okay in young patients. As you get older, your blood vessel and distal part of the body can be thickened and hardened, and you might not get as accurate a reading. So I would not encourage that, but it gives you a ballpark kind of figure to work with. The smart watches and all these gadgets that I have, they're validated to an extent, but we don't have enough evidence to say that that's the standard we should be using. They are just a guide. So we would always tell patients, all your smart watches and all those bits, even if they are there as like a screening. So if you recognize that it's high from the smart watches, we wouldn't use that reading to monitor your control. We will then still go ahead and measure your arm blood pressure. So there are good gadgets to have an idea what your blood pressure is like, but you should still have the recommended way of measuring it.
Okay. And once diagnosed, how do you manage high blood pressure? And what are some of the medications? And you mentioned lifestyle change and or adapting and lifestyle that a lot of times people might not necessarily want to subscribe to, but I guess it's important to stay alive.
It takes it's hard to change.
Yeah, yeah.
When we are accustomed to something, it takes a lot for us to change our lifestyle. So I appreciate that. But I always say to patients, I mean, tablet is not the answer to everything. We want lifestyle. We want you to look at your diet, exercise. So some of the things that we talk about, asked me before, salt. So you should reduce your low salt diet is important. High fiber diet. You should exercise regularly. Weight loss, you should try to have weight loss is known to reduce blood pressure. You should look at your risk factors, quit smoking, and reduce your alcohol intake. So that's your lifestyle modification. So that's the first thing I try to get patients to do, because what tends to happen is that if you rely on tablet, you may have to take more and more tablets. Whereas if you combine lifestyle, you may need less tablets. So we do lifestyle intervention, but of course lifestyle alone can't do it. Then you need medication. So if we quickly go to this medication, now I'll show you a slide that is recommended. How do we choose medication? So this is from the National Institute of Clinical Excellence. It's a UK guideline body that they will guide you, they will tell you, they make recommendations as to how do you manage blood pressure. Now, you know that there are lots of medication for blood pressure. How do we know when to choose, which one to choose, and why do we choose one drug over the other? So blood pressure is controlled. I tell patients this is a very important point to note. Patients will be given a tablet. They'll come back to me and say, Doc, I checked my blood pressure and it's still high. The tablet is not working. Can I get a different tablet? I say, hey, no. It means, therefore, the tablet is either not adequate, or the dosage is not adequate, or that alone is not helping. You need a drug from a second class. So I said to you, blood pressure, when you look at the dynamics of blood pressure, it has to do with blood volume, it has to do with heart rate, it has to do with the size of the blood vessel. So if you have, logically, if the pressure goes like that and the blood vessel expands, the pressure drops. If the blood vessel tightens, the pressure goes up. So when you're choosing drugs from different classes. So there are some drugs that control the blood volume. There are some drugs that control the heart rate. There are some drugs that control the size of the blood vessel. And that is how, so they're called classes of drug.
Okay.
And now, so the guidance that we have out there showed, the National Institute, they look at if you're under 55, greater than 55, also in Black ethnic group, you find that they have low renin level, is a chemical in their body, that they may not be as responsive to what we call ACE inhibitors. So that's a different class of drug, but we still give it in certain cases because it has other benefits, like in diabetic patients, kidney and all of that. Now, I just put this up just for people to understand that there are different drugs from different classes, and when we choose the type of drug we choose, it has to do with what other medical condition you may have. So for instance, if a patient has got diabetes, I will choose a drug from what we call an ACE inhibitor or ARB. So ACE inhibitors are ramipril, lisinopril, ARB are losartan, candesartan, irbesartan, just to say a few names to understand. Then you have calcium channel blocker, which is like your amlodipine. So if we have time, I don't know how we doing with time.
Well, go ahead. We'll put in a few.
Because I can go through quickly some of the classes.
Yeah.
So when we look at, as I say, the first line that I tend to give in under 55 years of age patients, I will put them on ARB, because ARB is called angiotensin receptor blocker, or ACE inhibitors, an ARB, the same family of drugs, but one work at a different stage than the other. So they are known to have other benefits, like protects the kidney, stroke prevention. It's got some studies showing that they have some other benefits. So you want to choose a drug not only to control your blood pressure, but if the drug has got other benefits over and beyond blood pressure control. Amlodipine is a commonly used drug, so people talk about that. That relaxes the blood vessel. Some of the side effects you can get is leg swelling. So when you have a side effect of a drug, I don't want patients to stop the drug completely. You may reduce the dose to half and the side effect goes away. So when you have so we start with one tablet, we start at a low dose. If the blood pressure is still high, we go to the higher dose. That's called a maximum tolerated dose. If the pressure is high, we don't stop the drug, we go to a second drug. We start at a low dose, we go to then go to the higher level. If the pressure is high, we at a third drug start low, go high. Because what we are doing, we're tackling the different systems I talked about. One work on the blood vessel, one work on the kidney, one work on the heart. So that's how you manage blood pressure. And I want patients to really get this and understand the management of high blood pressure, because there are lots of things, people will call in and say, or patients ask me, my friend is using this tablet, can I use this? His blood pressure is well controlled. But it's not as simple as that. You have to know what other condition do you have, how the drug works, what are the side effects. Lots of patients can have coughing from some of the blood pressure tablets. So ACE inhibitors, it causes you to cough. So we will swap that to a different tablet in the same family or mechanism of action. We can swap that to another drug. So these are some of the bits we need to use. But there are many, many drugs. We get classes of drugs from 4 or 5 different groups of drugs that we can use for blood pressure, but it can be adequately managed. And the important thing is to set targets. So I say our target for blood pressure, we want it less than 140/90, but you don't want to be sitting at that 140/90 level.
Right.
Most patients, I say, the evidence tell us, so normal blood pressure, when we say normal, if you're bang on in the middle, 120/80, you say that's it, because they then categorize blood pressure in stage 1, 2, 3 kind of thing. So 120/80, people say, oh, my blood pressure should be that. It's not quite that. As you get older, the blood pressure goes up. So we aim for 130/80 in most patients, diabetic heart disease patient. So you don't want to be top at 140/90, 130/80. That's your target.
Okay.
In complicated older patients. Just one point to make in elderly patients over 80, for instance, the guidance tell us, sometimes, so what gives you the top and bottom number? When the heart pumps, it squeezes blood, it gives you the top number. And when the heart relaxes, it gives you the bottom number.
Right.
So some patients, as you get older, the blood vessels stiffen, it hardens.
Right. So the reading is
so when you have compliance of the blood vessel stretches, it balances the pressure. But if it's stiff and hard, when the heart squeezes, it can't expand.
Right.
So the pressure gets high. So that's your systolic high blood pressure high. So in elderly patients over 80, we accept 150 as a guidance, because sometimes what happens, you're treating the top number. So there's no tablet that only treats top or bottom number. It treats them both.
Right.
Right. So what tends to happen, you may have a high top number and the bottom number is dropping too low, especially in older patients. And you cannot go up to a certain level, because if you drop the bottom number too low, you will get dizziness and you fall over. And in those patients group, we don't want that. So you have those limitations, but by and large, Yeah.
All right. So let me I want to touch on one more thing. We talk about hypertension, high blood pressure.
Yeah.
Let's before in closing talk a little bit about low blood pressure, because obviously that's another thing.
Correct,
And I hear a lot of people saying, oh, when that they gotta drink this. I don't know which one is blood pressure, but they gotta blend this cucumber with ginger or something like that, drink that to regulate. But what is low blood pressure?
No, so okay.
And should we be worried about low blood pressure like how we are about high blood pressure?
Yeah, obviously. I mean, we shouldn't be as worried, because I can tell you what, majority of low blood pressure is now real low blood pressure, right? So, as I said, the threshold, the top number 90 to 140, bottom number 60 to 90.
Yeah.
So if the top number is less than 90, that's considered low. If the bottom number, that's a diastolic, less than 60, that's considered low. So we may define low blood pressure as anything under 90 on top and anything under 60. So 90 upon 60 and lower is defined as low blood pressure. But actually, most of the patients, there are not many diseases that will give you low blood pressure.
Okay.
Most low blood pressure is caused by what we call secondary causes. So if you're dehydrated, you're heat exhausted, your blood pressure can drop. You're dehydrated, there's less volume in your body, your blood pressure can drop. We find that lower blood pressure, you can have that in lots of young girls when they have their period time, they're bleeding, they have low blood pressure. However, it is important. I wouldn't be dismissive of low blood pressure. So we would look at, our body has some mechanism that when we sit and we stand, the pressure changes to adjust that. So if you have something called orthostatic hypotension, where the blood pressure lowers, when you stand up, it doesn't go up. You feel dizzy, you can
Right,
fall
right.
over.
Yeah,
So
yeah,
there are causes for that. Either your receptors are sluggish, or there's some medication you're using that doesn't allow the response to be so fast. But when we have low blood pressure, we want to ensure that there isn't another medical condition. So there are conditions like endocrine. There's a condition called Addison disease, where you're producing low steroids in your body, because steroids maintain your blood pressure as well. So it may be bad. Too much is bad as well,
Yeah, yeah.
and too little is bad. So I would say generally low blood pressure. Ensure you're well hydrated. See your doctor. Look for secondary causes, endocrine causes, anemia, and whatever the cause. But generally, it's not a worry.
All right, great. Doc, we're closing off here today. Next week, you and I are going live. I know that our viewers are going to be looking forward to that. We'll be live starting next week on the 8th of October, Tuesday, the 8th of October. You can call in. You can tell your friends and family that they can tune in and watch us live. We will be here. We're going to be taking your calls. First 15 minutes will be just before us to discuss whatever topic we're covering for that night. But of course, you can call in with whatever is bothering you, and Doc will do his best to answer your questions. Anything in closing today?
No, I think we have touched on a big topic, and yes, I can't do justice to the topic in one episode, but
Yeah.
I'm sure, as you say, that once we get
Right, because when the call-in starts to come in,
Correct.
people
I'm
are
looking
gonna
forward
ask-
to that.
Yeah.
Yeah.
All right, Ma. Well, thanks so much, and
Thank you
we're
again,
doing this again
Sal.
next week. So again, viewers, thanks for joining us. As I said, I can't wait for our live call-in from next week, Tuesday. So join us, and remember to stay healthy and watch out for those who are not watching out for you on the road.
Thank you.